Awesome.
Perfect.
All right. Well, we are so excited to have Dr. Adam Duke here, who specializes in endometriosis excision surgery. He actually did my surgery a couple of weeks ago, and I am feeling quite amazing and very grateful to him. But I know there's lots of kind of misconceptions and kind of myths about endometriosis, so just wanted to hop on and kind of have you share a little bit more. So let's kind of first talk about like what is endometriosis? Because I think there's a lot of kind of misconceptions starting off right there.
Yeah, there are. Yeah. So there, I mean, there are misconceptions even within the medical world about endometriosis. And the simplest definition of endometriosis is that it is tissue that is similar to the endometrium. The endometrium is what a person who menstruates will slough off every month when they have their period. And then it regrows in anticipation of an embryo implanting. And if you don't get pregnant, it sloughs off again. And that cycle is what kind of makes up the menstrual cycle. So that tissue that is the endometrium contains glands. We call it glandular tissue. But endometriosis is tissue similar to that, but it's obviously not inside the uterus it's supposed to be. So it is, sort of ectopic or outside of the uterus. And the critical thing to understand is that endometriosis is not endometrium. That was based on Samson's theory, where they thought that endometriosis came from retrograde menstruation, or you would menstruate out the fallopian tubes, and then somehow it would implant and wreak havoc. That theory has been disproven by a number of things that we can talk about, but that unfortunately still is kind of the prevailing theory, even within kind of the OBGYN world. And so endometriosis, and we'll talk more about, treatment, but endometriosis essentially gets treated like endometrium, even though there's hundreds of genetic differences between it and regular endometrium. So
How long ago, like you said, that's kind of that was the thought for a long time, but how long ago did this kind of new idea or, come about? Like, is it pretty new or that's been,
in terms of endometriosis not being endometrium, I mean, I
yeah.
think really that kind of started probably with David Redwine's work in the late 90s. So the Samson's theory had been the prevailing theory for 150 years, or I can't remember exactly when he came up with that theory, but around 100 years, 150 years. So it's been kind of the prevailing theory for a long time. Um, so all of our understanding of endometriosis really is new. Is the best way to treat it, the best way to or the best way to kind of understand the pathophysiology of it and how it acts. I mean, this is all relatively new. If you think about the long history of medicine, and this idea, this paradigm shift has really only happened in the last 20-25 years. And there are a lot of people who still don't subscribe to it. And like I said, I think, most of the general OBGYN world is still kind of operating under this idea that endometriosis is endometrium, and therefore the best way to suppress endometriosis is to suppress it like you would endometrium if you're trying to stop a patient from, having a period. And that is where sort of the dangers lie in the treatment of endometriosis, and why so much of it is really frankly archaic. And we're probably 30-40 years behind where we should be in terms of how we treat endometriosis. So
Is the old kind of idea of it still being taught in medical school? And so a lot are kind of,
yeah, yeah,
okay.
I think so. I mean, it's been 20 years since I've been in med school, but yeah, that was what we still learned. That being said, I mean, didn't we didn't really learn much about endometriosis in medical school. I remember the first time I even heard endometriosis was actually as a third year medical student. I don't remember ever hearing it as a first or second year, when you're learning all your anatomy, physiology, basic
Yeah.
science courses your first years, and then your third and fourth year of med school is when you're doing your clinical rotations. And I was doing a family practice rotation, and A young girl came in with kind of chronic abdominal, she's like 15, 16, came in with chronic abdominal pain and menstrual pain. And my my preceptor, Dr. Anna Labadan, was asking me, if I thought it was endometriosis. And that was really the first time I remember hearing endometriosis.
Yeah.
And I looked it up in my Robbins pathology textbook that I kept in my little white coat,
Mhm.
and it still had the definition of endometriosis as being retrograde menstruation. So that was, when I was in med school. And then when I was in residency, I I mean, residency is kind of a blur because it was 4 years of 80 to 100 hours a week working, sometimes more. And so those 4 years I've kind of mentally blocked out, but I don't really ever remember learning about endometriosis in my residency either,
Okay.
uh, which is kind of scary, right? Like that's, I feel like
Yeah.
that's
Was
something
that
that should
a
be,
OBGYN residency
yeah,
too?
yeah, for an
Okay.
OB/GYN
Wow.
residency. So for something, a disease that affects 10% of your patients, there probably should be quite a bit dedicated to it. At the time that I was going through residency, there was this big push by ACOG, which is the American Congress of OBGYNs, kind of our overarching body. They really were trying to turn OBGYNs into basically primary care doctors for women. And so women didn't have to, so they could come to the OBGYN and they could get their cholesterol checked and their thyroid managed and all of stuff. And I remember that was the big push when I was in residency. And so I remember having tons of lectures on hypertension and hypothyroidism and hypercholesterolemia. And like, I don't really remember ever learning about endometriosis as an OBGYN resident. I remember learning about high blood pressure and thyroid problems.
Hmm.
And that's obviously another big problem,
Right.
because we're not primary care doctors. We're not OBGYNs are not primary care, nor should they be. There's a role for specialties within the medical world, and I think for a long time OBGYN was trying to fill a lot of different shoes, so they could be kind of a one-stop shop. And when you're a one-stop shop doctor, it's really hard to sort of specialize in one particular thing when you're having to learn 85 million primary care topics. So
Yeah. Would you say now, like the majority of OBGYN is focused on delivering babies still? Like, is that kind of more the main focus too,
I
compared
think
to like,
so. Yeah. I mean, for as an example, I graduated my residency with something like 400 or 500 C-sections in 4 years. And I only did 70 hysterectomies in 4 years. And
oh,
that
wow.
was, I was even like I was one of the more aggressive residents about trying to get surgery. So I would stay sort of beyond, you ran over your 80 hours, like to stop what you were doing and go home to rest. There was like this big push, but I would stay behind post call and do surgeries because I was really trying to get that surgical experience. But I had, people in my class, for instance, who weren't as aggressive about getting surgery, like graduate with like 15 hysterectomies in 4 years. And so we've sort of like turned loose this generation of OB/GYNs who 85% of their training is obstetrical related. I could manage preeclampsia in my sleep. I could manage preterm labor in my sleep. I often did. But doing a hysterectomy, I felt comfortable with it, but doing a complex endometriosis surgery, there's no way. You're not prepared to do that. And it wasn't until I sought out a 2 year fellowship in minimally invasive gynecology because I really knew that I didn't want to do obstetrics. I think kind of the reason I went, to give a little bit of backstory, I went into
Yeah.
OBGYN because I had this really, really charismatic OBGYN professor my third year of med school named Dr. Fleming, Al Fleming. And he was a great guy. He was a maternal fetal medicine doctor, and like very inspirational. I think inspired a lot of people to go into OBGYN. And then I was about a year into my residency and realized it really wasn't what I wanted to do. The up all night, waiting on babies, delivering babies. And I knew that I wanted to do something surgical. And so I actually considered um, dropping out of my OB/GYN residency after my first year and joining a general surgery residency because I knew I wanted to do the surgery aspect of it. But then somebody had mentioned, well, what if you stay in OB/GYN, but like just do surgery and not deliver babies? And so I knew that the only way to do that would be to pursue one of these fellowships. And I also didn't want to start over. Like I'd already done a year, and your intern year of OB/GYN is probably the hardest, most grueling year of your life. And I didn't want to like have that be for nothing and then have to start over and do another intern year on general surgery. So I just kind of stuck it out.
Hmm.
So.
At what point, like, were you thinking you wanted to specialize more in like endometriosis excision, or kind of when did you first become aware of that technique?
I didn't in residency. I I don't remember ever seeing an excision surgery. I thought for a little while that I might want to do GYN oncology because I really liked my GYN oncology rotations in residency where they were doing these really big cancer debulking surgeries. And um, I had always kind of been drawn to the chronic pelvic pain world a little bit. I think a lot of residents, they see those patients on their schedule and they're like, ugh, and a chronic pelvic pain patient, I don't, but she just wants opioids, or, she's crazy or whatever, all the things that kind of get thrown around. And I was actually drawn to it because having watched my own mom has some of these chronic pain issues, interstitial cystitis, endometriosis type stuff. And so I'd kind of been drawn to that world a little bit. Um, but I don't remember us really ever doing any actual endometriosis surgeries. I really don't. Like, I don't remember watching a single endometriosis surgery in residency. And if we did, it would have just been a hysterectomy. And we'll talk
Okay. Yeah,
more about
yeah.
that in a little bit about why that's not the treatment. But um, yeah, it was just something like I knew I wanted to do surgery, and I knew I wasn't really in love with delivering babies at 2 o'clock in the morning. Um, and so I was kind of debating between, I was kind of kicking around the idea of doing a GYN onc fellowship because they do really cool surgeries, but their patients are also really sick. And, most of them need a big surgery. They get admitted to the ICU, they're there for a week, and you're rounding on them at 4 o'clock in the morning every day. And it's kind of a crazy lifestyle. And then someone had mentioned these minimally invasive fellowships. And so I started pursuing those and looking into them, um, kind of doing a little bit of a deep dive into that. And that was during the end of like my third year of residency. And that was when I kind of knew that I wanted to do a MIGS fellowship.
Hmm.
So,
Nice. Very cool.
yeah.
Well, tell me a little bit more. We kind of, alluded to different treatment options. So what is kind of the typical OBGYN approach to treatment? And then kind of what does your approach look like?
So, I mean, typically, and these are recommendations that come from ACOG. There's sort of a tiered approach to the treatment of endometriosis, and generally that is to start with. Well, first of all, it's usually to like ignore it. It's usually like, oh, I don't think you have endometriosis, but I have all these symptoms. Well, have you thought, that it might be this? And so typically it'll either get ignored, or patients will get sent to gastroenterology for their IBS workup, and all these patients get. And this typically starts as like a teenager when these 15, 16-year-olds are coming in and they're complaining of bloating, nausea, diarrhea, constipation. I mean, that's endometriosis until proven otherwise. But there's this trend towards, well, with these teenagers, it's either, well, that's just how, that's just how it is for some patients. Maybe you're stressed, maybe, you're a teenager and you're in school and you're trying to play sports, and, maybe you're just depressed or anxious or stressed out. So, why don't you try to relax a little bit, and then maybe your symptoms will get better. And then if they do suspect endometriosis, after, ignoring it for a while, if the patient keeps coming back and saying, no, something's really wrong here, okay, we'll send you to GI. GI will do an endoscopy and colonoscopy on you. Well, that's normal. Okay, we're back to it's probably just in your head, or it's probably this is just normal. This is just how it is for you. And then if they finally are, sort of begrudgingly are willing to admit that yes, the patient probably has endometriosis, there's this tiered approach to medical treatment, which is start with NSAIDs, so ibuprofen, Aleve, those kinds of things to try to decrease pain and inflammation. If those don't work, then we go to oral birth control or a patch or a NuvaRing or things like that. If one of those birth controls doesn't work, it's let's try a different one. Well, that one doesn't work. Let's try a different one. And so suddenly you have these 15, 16, 17-year-olds who've been on like 8 different birth controls. There's never been a single birth control or hormonal contraceptive that has been shown to be superior to another one. So this idea of like, well, that one didn't work for you, let's try this one. Well, that one didn't work, let's try this one. So there's never been one that's been shown to be superior to another. And that includes for things like Lupron and Orilissa, and those become the next tier of the treatment plan is like, well, birth control doesn't work for you. Okay, now we're going to try a medication that basically shuts down ovulation, shuts down your body's natural estrogen supply, with the idea being that if we turn your estrogen off, we'll starve the lesions of endometriosis and we'll make them shrink and go away. It's been known for a long time that endometriosis lesions actually produce their own estrogen supply. So you can starve endometriosis of estrogen all you want; those lesions are still going to be there. And so that means those lesions can even be there after menopause. They can be there after the ovaries come out, and they can be there, despite being on hormonal suppression. And I think one of the keys to really understand with any kind of medical treatment of endometriosis is that none of those medications are actually FDA approved or designed to treat the disease. They are FDA approved and designed to treat the symptoms of the disease. So if you put, and that's a really critical distinction. So if you put a patient on a birth control or Lupron or one of these medications that suppresses menstruation, suppresses ovulation, suppresses your estrogens, but you're not actually treating the disease. You're just sort of kicking the can down the road a little bit. And if you're a very busy, friendly neighborhood OBGYN who has 30 obstetrical patients in your office every day that you have to get through in order to keep the doors open, which because reimbursements keep dropping across the board, you don't necessarily have 30, 40, 50 minutes to spend with a new endometriosis patient or with an endometriosis follow-up patient. And so it becomes, well, try this birth control, come back in 3 months. Try this birth control, come back in 3 months. And then, patients are on this merry-go-round for years before they finally, and that's why it takes on average 8 to 10 years to get an official diagnosis of endometriosis, because it's this constant try this, try this, try this, try this, see me back in 3 months, try this, see me back in 3 months, try this, see me back in 3 months. And so, again, it's not actually treating the disease. And so, and surgery's not perfect either. And we'll talk about the ins and outs of surgery and the difference between fulguration and excision and all that. But that tiered approach to endometriosis has kind of been the standard for I don't know, 100 years. And if you read still the ACOG practice bulletin on endometriosis, that is still how it's done. It's NSAIDs first, birth control, and then followed by a GRNH, what we call a GnRH agonist, which is Lupron, and really only surgery as a very, very, very last resort. And I think most excision surgeons or endometriosis specialists want to see that pyramid flipped, where we have access, everybody has access to excision surgery to A, diagnose the disease, but B, to try to treat it and remove it so that it doesn't become a much bigger problem later down the road, especially when fertility is a concern. We can talk more about that too.
Yeah. I feel like I've heard a lot of people say, oh, like, I knew somebody or so-and-so or my sister, whatever, had endo and then got pregnant and it went away once they got pregnant. Is that like what is going on there?
That's completely not based in reality. There's this idea that progesterone helps minimize symptoms of endometriosis. Again, does not treat endometriosis, but it can help with the symptoms. And when you are pregnant, your estrogen level goes up, but your progesterone level goes up much higher. So pregnancy is a relatively hypoestrogenic state in which, even though your estrogen is higher than baseline when you're pregnant, it's not as high as what your progesterone does. And so there's this idea that pregnancy, because of that high progesterone level, will suppress some of those symptoms. And some of those symptoms do go away, but for a lot of patients, they don't. And certainly as soon as the pregnancy is over, and those progesterone and estrogen levels kind of fall back down to normal level, those symptoms are still going to be there. So pregnancy is absolutely not a cure. And the interesting thing, and that idea was like totally rebutted by again David Redwine.
Okay.
Uh, that idea that pregnancy cures endometriosis was literally based on one case report where they looked at endometriosis lesions in a pregnant patient and found that the progesterone had sort of caused almost like an atrophy or
Mm.
necrosis of these endometriosis lesions. But the funny thing is that when David Redwine went back and looked at the original slides from that case report on which we've based the entire notion that pregnancy cures endometriosis on one patient, one case report,
Mhm.
uh, those slides that they were looking at probably weren't even endometriosis. So they weren't even using endometriosis tissue to make that assumption, which is kind of
Gotcha.
crazy. Yeah.
That's wild. Yeah, yeah. Interesting. Let's talk a little bit more about kind of surgery techniques and what traditional surgery techniques have been versus what excision is.
Yeah. So most OBGYNs are going to do what's called fulguration surgery. And a fulguration surgery is where you burn the disease. Now, obviously, you're not going to burn it if it's on bladder or bowel or ureter or diaphragm or kind of these more critical structures, and nor should you. You shouldn't be burning a hole into an endometriosis lesion that's sitting right on top of the rectum. And so when you burn disease or fulgurate it, you're typically going to miss a lot of the disease. And I read countless op reports, countless that are like from other doctors and patients who get referred to me that like, we fulgurated all the areas we could except for the ones near the bowel bladder ureter. Like it actually says that in the operative report. And I mean, that's fine. You shouldn't be doing that. But if you're not prepared to sort of remove all the lesions and you're just going to burn half of them and leave the other half there, you really haven't done the patient any kind of a service. In fact, when you burn it, I think you create adhesions and you flare things up. And so you probably make that patient's pain worse.
Mm.
Um, there is data, and again, we try to be as data driven as we can, that for very superficial peritoneal lesions, that there is no difference in pain scores um, when you burn or excise for very superficial disease. But you don't know the disease is superficial necessarily until you get in there. And so
Gotcha.
there's really not a good way to know if disease is superficial or not until you're in there. And so if you go in and there is just very superficial, just on the peritoneum, yes, you can fulgurate that and you'll probably destroy those lesions. But if there's any kind of disease that's infiltrating deeper or is on bowel bladder, critical structures, you're not going to touch it by, you're not going to do anything with burning it.
Okay.
And very rare that endometriosis is like just superficial lesions on the peritoneum. So
Gotcha.
the vast majority of patients who have fulguration surgeries are going to have untreated disease, disease left behind, or disease that just comes right back. And so excision surgery, the idea behind it, and this was really pioneered by, there's like kind of three godfathers of endometriosis. There's probably more, but the three that I kind of remember, this Harry Rich, who did the first laparoscopic hysterectomy in the country, C.Y. Liu, who was one of my mentors, and David Redwine. Like they were kind of the big ones that were like, hey, we really need to be cutting this disease out, not burning it. It's kind of a similar approach to cancer. You would never ever go in and say, "Oh, there's a cancer there. Let's just burn it and hope that it goes away." You would cut it out. and remove it. And so that's the basis of excision surgery, is to actually try to remove the disease and cut it out of the body. It's not perfect either. And we do have a, the people argue about the recurrence rates. I think most of us would agree, most excision specialists would probably agree that it's around 20% recurrence rate. Some think it's higher, some think it's lower, but I think that's kind of a good, middle of the road number. But if you go in and you burn disease, or you just ignore the disease that's on the bowel or bladder, it's like 100% recurrence rate of disease.
Mhm.
So if you're not even treating disease, then of course it's still going to be there. So excision surgery, yes, it's not perfect, but it does have a significant advantage over just burning the disease, where it's going to come back virtually 100% of the time. Um, but excision surgery, by its very nature, is a little bit riskier, because I am cutting into bowel, I am cutting into bladder, I am cutting around ureters, and sometimes you can injure those structures. Sometimes you can injure a bowel or bladder, and you got to call in, someone else, or call in another member of your team. And that's why I think it's so important to have a multidisciplinary team. I work very closely with the general surgeons at my hospital, who are willing to jump in, and if we need to do bowel resections, they do them, and they're willing to kind of help. Because if I didn't have that, I would feel a lot less comfortable
Yeah.
being aggressive with bowel endometriosis. If I didn't have that backup. You have to have that backup, because if I didn't have that, and every time I encountered bowel endometriosis, I was forced to ignore it because of the small chance of having an injury. Um, but so yeah, our excision surgery is, again, by its very nature, a little bit riskier. And the complications, if you do have a complication in the excision world, it tends to be a little bit more serious. It's usually a bowel perf, and they're rare, but I've had them. Um, and, so you just have to kind of be prepared that if you're going to be doing these types of surgeries, you're going to have a complication at some point. I don't know a single excision surgeon that's never had a single complication.
Okay.
And that's just the reality of it.
Yeah. Can you talk a little bit? So you hear like adhesion, scar tissue, endometriosis tissue. Are those all pretty similar, or are there kind of big differences between those?
Well, there's big differences between them in terms of, endometriosis is endometriosis. Adhesions, the idea of adhesions is where there's been an injury to tissue, and then other tissue will stick to it. Now, that can be because of prior surgeries. That can be because of endometriosis. So endometriosis can cause adhesions.
Gotcha.
Endometriosis can cause scar tissue. The idea behind endometriosis eventually becoming scar tissue is that over time, endometriosis lesions can sort of burn themselves out, in terms of they're no longer hormonally active, and with estrogen receptors and progesterone receptors, but they just basically turn to chronic inflammatory tissue, which can still be a source of pain for patients. And that's kind of what we call like scar tissue. Now,
Okay.
scar tissue can also occur where you've excised. So if you excise, anytime a scar is a scar, right? You cut your arm,
Mhm.
you got a scar there. And so anytime there's tissue damage, you're going to form a scar there. And so if you're doing these massive excision surgeries, you are going to form scar tissue where you've excised. The idea being that scar tissue is not as painful as active endometriosis lesions. Um, and then adhesions, there's debate whether or not adhesions are really a source of pain. I mean, I think they're like, if you have all of your bowel stuck together, or stuck to the anterior abdominal wall, or it's all wrapped up in adhesions, that's going to cause pain. That will be painful. So that's kind of the difference between the three things, but they're very different from one another. But they're probably, you know, one thing, endometriosis can cause the other two things,
Gotcha.
essentially.
And
Yep.
probably more like histologically different, but like functionally pretty similar, I guess, and
They
kind
can be,
of,
yeah, they can
yeah.
be. Yeah. So yeah, histologically, they are very different. But they can behave similarly in terms of causing how they cause pain. Yeah.
Gotcha. Gotcha. What are some kind of big symptoms or things that you're looking for? Like, as people come in to see you and they're, talking about what they're going through, what are kind of big like red flags or things you're like, oh yeah, that's probably endo.
I mean, any kind of pain that's otherwise, undiagnosed pain. Now, not all pain is endometriosis, obviously. But if a patient comes in and tells me that they have pelvic pain, especially if there's a cyclical nature to it, like, oh, yes, when I'm around my cycle or I'm around ovulation, my pain gets significantly worse, that's endometriosis. Furthermore, I think often overlooked are the gastrointestinal symptoms. So there's bloating, nausea, vomiting, diarrhea, constipation. So much of that, especially in teenagers, gets chalked up to IBS, or you have Crohn's or ulcerative colitis. But I mean, this diagnosis of IBS gets thrown around all the time. Um, if you're a teenage girl who has cyclical nausea, cyclical vomiting, that's not IBS. It's endometriosis. And in teenage girls, and gastrointestinal distress is the most common symptom, even more than pain. So if you have a teenage patient who has all of those gastrointestinal distress, 999 times out of 1,000, you're going to find endometriosis in there if you operate on them. But there can be other things. Painful bladder can be a part of it. Painful sex can be a part of it. Pelvic floor pain, uh, painful bowel movements. So I think the overarching theme is either gastrointestinal distress or pain of some kind, especially in a cyclical nature. Now, there are patients who have this term called silent endometriosis, and those are patients who their only symptom is infertility. And I think unexplained infertility is, and this is my bias as an endometriosis specialist, but I think unexplained infertility is also endometriosis until proven otherwise. And I think that those patients with unexplained infertility or subfertility probably ought to be scoped by a specialist as well to look for endometriosis. I've had patients referred to me and they have discovered as part of I have a couple of reproductive endocrinologists in Montana and Washington who like send me all their patients for endo, and some of these patients will have zero pain whatsoever, but as part of their infertility workup, it's discovered that they have bilateral endometriomas or cysts of endometriosis on the ovaries. And you go in and it's like some of the worst endometriosis you've ever seen in your life. And their only symptom was not being able to get pregnant. And that's kind of what we call silent endometriosis. I think if you start doing a deep dive into those patients' pain patterns, um, I don't I think you'll discover that most endometriosis is not silent, but I
Mhm.
think some of their pain and some of their symptoms, their gastrointestinal issues have kind of been normalized either by their own families or by medical professionals. And so if you really start diving deep into their symptoms, I think you'll discover that most endometriosis is not actually silent. So there's
Okay.
always
Yeah.
something. Yeah.
Yeah, I mean, I fall, I think, more into that category. I mean, a little bit of painful periods, but nothing like debilitating. Never missed school, never missed, volleyball, sports, things like that. And then I know you found like stage four in there for me, and it was a lot more of like infertility too, that
Right.
I was, suffering with. And I was like, yeah, I don't have endo. It's not crazy painful like everybody says it is. And that's always kind of interesting to know. I know you kind of talked to like the stage of endo doesn't necessarily correlate to symptoms either, right?
Correct. Yeah. So the staging of endometriosis was something that came around, gosh, I want to say in like 1978. I think the ASRM, American Society of Reproductive Medicine, was basically trying to standardize the research regarding endometriosis and fertility and sort of the way that clinicians and surgeons communicate with each other. Um, so we know what each other's talking about by staging endometriosis. If an op report is just like, oh, the endometriosis was really bad, I don't know what stage that is. Um, so the staging system came about as a way to sort of um, allow for surgeons and clinicians from a research perspective to be able to communicate with one another in terms of the severity of disease and kind of standardize that really for research purposes. It has nothing in the real world, it has no application whatsoever. Um, I think patients are always like, what's, that's the first question I said, what stage was I? What stage was I? I was like, well, you were this, but it doesn't matter because as you just alluded to, the stage of disease really has no correlation at all with pain levels or with fertility levels. And that was kind of the idea, was that, like, the worse, the higher the stage, the worse the fertility issues would be, but that has not been the case at all. I have some patients who have debilitating pain, who have like two superficial lesions. And then I have patients like you, or, I've seen hundreds of others with stage 4 endometriosis who don't have any pain at all, but they have bilateral endometriomas, their rectovaginal septum's completely obliterated, everything's stuck to everything, and they don't know it. So yeah, that just, really reiterates that point that the stage really doesn't mean anything in a real world application.
Yeah, well, let's talk a little bit about kind of fertility and endometriosis. We kind of talked about it, like that doesn't necessarily correlate to the stage, but kind of what do you see, like treating people that are coming to you for infertility? Like, what does success rates kind of look like that for that after surgery?
So we have a pretty good track record for patients being able to conceive naturally after surgery. Um, Endometriosis, sort of across the board, has a 50% infertility or subfertility rate associated with it. So, of the patients who have endometriosis, whether it's stage 1 or stage 4, 50% of them will have subfertility or infertility. Subfertility meaning, trouble getting pregnant, essentially. Um, and so the process by which that happens is there's a couple of factors. One is, if you boil endometriosis down to what it is at its essence, it's very, very highly inflammatory tissue. And little embryos that are getting fertilized at the end of the fallopian tube and then spending 2 or 3 days traveling down before they even get to the uterus and implant into that endometrium. Those embryos, if they're exposed, so fertilization, a lot of people think fertilization happens in the uterus. It doesn't. It happens like in the ovary. So the sperm kind of goes all the way up through the fallopian tube, meets egg, and then it travels back down. And so if you've got a very, very highly inflammatory process happening around where that fertilization is occurring, it's going to wreak havoc. And so that's where the infertility, subfertility aspect of it comes from. Furthermore, if you have more advanced disease, you can have tubal obstruction. You can have, the tubes get wrapped around, they get stuck to other things. You can have clubbing of the fallopian tubes, or the fimbria of the fallopian tubes get clubbed and they just can't pull that egg back down. So there's some anatomic factors that can happen with endometriosis, but from a cellular inflammatory level, that's kind of that it's a very dumbed down, simplified
Yeah.
version, but that's essentially kind of what's happening, is that inflammation there. And I don't know how much you want to talk about adenomyosis, or that's
Yeah, we
something,
can go into that too. Yeah.
talk about adenomyosis. So adenomyosis is where the glandular endometrium, you slough off, that actual endometrium works its way out into the muscle layer of the uterus. The uterus is one big muscle, and it's what contracts when you're having contractions to squeeze a baby out. And so when that muscle of the uterus gets infiltrated with glandular endometrium, that's adenomyosis, and that also creates a lot of inflammation within the uterus itself. Now, that doesn't necessarily correlate to a decreased fertility aspect of it, because fertility can still happen with adenomyosis. But what we associate adenomyosis more with is increased risk of miscarriage, because the fertilization kind of occurs elsewhere. The egg comes down, it tries to implant, and it's trying to implant into an area that's also very inflammatory within the microcosm of that womb itself. And that's where the embryo just says, I've had enough of this, I'm out, kind of thing. And so that's why we see more recurrent miscarriage with adenomyosis versus the infertility with endometriosis. And so when we're treating endometriosis, the idea is that if you can remove as much of that endometriosis as possible, or all of it ideally, I mean, in the vast majority of cases, we're removing all of it. There are some rare instances where we do have to leave a little bit of endo behind because we could impair fertility by removing it. You know, we can't remove if it's like all over the fallopian tubes. It's like, do you try to get that off? Do you damage the tubes? Do you, you know, sometimes you do have to leave some endo behind. But the idea behind the fertility aspect of it is that if you can get all of that inflammatory tissue out, or as much as humanly possible, or as much as possible as the surgery will allow, then you do improve fertility rates. And the data is fairly clear on fertility rates improving following surgical treatment of endometriosis. And there was a big meta-analysis done, it was like 2019, 2020, maybe it was earlier, might have been earlier, but it essentially was saying that if you surgically treat endometriosis from an IVF perspective, the egg retrieval, oocyte retrieval rates are higher, the successful
Mhm.
implantation rates are higher, the live birth rates are higher. So there is pretty clear-cut evidence that treating endometriosis prior to getting pregnant really does improve outcomes. And I've seen that on an anecdotal level. I've had so many patients who've even gone so far as to have IVF. They've done the whole cycles, they've done the egg retrievals, and they just cannot get pregnant. And then you do an excision surgery on them, and they're able to spontaneously conceive, and that's a pretty cool thing. And we do have that happen all the time, like all the time, to the point where it's not a coincidence. It's not
Yeah,
a
yeah.
we are doing something that's improving their fertility. So
And you talked a little bit about adeno kind of being more of like miscarriages rather than like infertility. And I think we talked, but there's not really a good treatment for that, right? Like you're kind of just stuck with that a little bit
yeah,
unless you want a
yeah,
hysterectomy.
that adenomyosis is hard, especially in a young person who's trying to conceive actively or they want to conceive someday. Because adenomyosis is a disease of the uterus, the definitive management of adenomyosis is a hysterectomy, is removing the uterus, not the ovaries, just the uterus. And so in a young, you have a 19 or 20 or 25-year-old or 30-year-old or whatever who's actively trying to conceive, there's not a lot of great treatment options for adenomyosis. It is kind of unfortunately like a deal with it until you're ready for a hysterectomy. Now, but that being said, doing an excision surgery is, most patients with endometriosis will have pain throughout this, not just with their cycle, but kind of throughout the month. Usually starts just with cycle as a teenager, and then it kind of progresses where you're having pain most days of the month, 20 days out of the month, 25 days out of the month, intense ovulation pain. So if you can do a successful endometriosis excision surgery, if you can get a patient to the point where they're only having pain for 2 or 3 days out of each month, and it's just while they're on their cycle, most patients, that's a good trade-off. They'll take
Yeah.
that. Um, but the other treatment options for adenomyosis are to try to suppress the endometrium or suppress menstruation. And that's where things like a Mirena IUD can be beneficial, some kind of continuous hormonal control. I'm a fan. If I'm going to use any hormonal suppression, any birth control, I'm usually an IUD guy.
Okay.
Um, I find that it has fewer side effects than combined. It's progestin only, so you don't get the estrogenic side effects like the headaches, the bloating, the weight gain, the breast tenderness, the mood swings. So if you're using progestin only IUD, I find that to be probably the most helpful for shutting down menstruation. In a patient who's maybe 18, 19, who kids are not on their radar for another 6, 7, 8, 10 years. I think IUDs can be beneficial in that regard. Um, but you are kind of stuck sometimes with adenomyosis, and that's a hard conversation to have with patients. Like, hey, your uterus is extremely inflamed. You have horrific, painful periods. And one of the hallmarks of adenomyosis, I know you know this, but people
Yeah.
watching might, is that the adenomyosis, kind of the hallmark of it is heavy, clotty bleeding. And there's a misconception, even in the OBGYN world, that endometriosis causes that. It does not. Endometriosis, by definition, is outside of the uterus. So it has no effect, no bearing on the amount of bleeding that you're having. So heavy, clotty, period bleeding, if you're passing the dark clots and having intense pain, that is adenomyosis. That is not endometriosis. And so adenomyosis, yeah, you are kind of stuck sometimes because it's either suppress with an IED or birth control or whatever, or hysterectomy. And so there's not a lot of in between. And so in a patient who's trying to conceive, you can't do either of those things.
Right.
So it does become a case of, yeah, we're just going to kind of have to deal with this until you're ready for that uterus to come out, essentially.
Is there, when it comes to clotting, like, should there be no clots at all, or is there kind of like a size that you get like concerned about?
No, I mean, there's no real size. I always just tell patients, or, if you're having clotty, heavy periods, especially if it's accompanied by pain, that's
Mhm.
adenomyosis generally. Um, these are patients who are typically are like changing through a tampon every hour or two. Like that's not normal.
Okay,
So if you're having bleeding to the point where you're like anemic, I mean, I have patients who are bleeding, their periods are to the point where they're having to get iron transfusions because they're anemic.
gotcha.
Um, that's not normal. So everybody's normal is a little bit different, but generally, I mean, if you're bleeding to the point where you're changing, multiple pads a day or every hour, or you're anemic, or you're passing huge clots, like that's not normal. But there's no like, I'm not aware of anybody that's ever
Okay,
like measured the size of the clots and said this is
gotcha.
abnormal. Yeah.
Gotcha. I think, and that might have been more of like miscarriage of like if you start passing clots greater than a quarter, or if you've like miscarried and start passing clots like a size of a quarter again, that's like a cause of concern. So I wasn't
Yeah.
sure if there was like a kind of like
Uh,
a, oh, if they're minimal, it's okay, but if they're, thumb size, quarter size, we're now concerned. But
yeah, not really from in a
yeah,
non-pregnancy. So,
gotcha. Gotcha.
yeah.
You've talked a little bit about interstitial cystitis.
Mhm.
How does that play into endo? I don't know. I know you said kind of things can run together, but they're not always like related.
So interstitial cystitis is a disease of the bladder, and the hallmarks of IC are frequency, urgency, pain with a full bladder, and then in some patients, it's actually feeling like you have a UTI.
Hmm.
It's um, something that we do associate with endometriosis. I think for a long time we were probably over the pelvic pains in the pelvic pain world. We were probably over diagnosing interstitial cystitis. There was some data that came out of University of Tennessee that was presented at the AAGL, which is our big national conference in when would that have been 2014 or 16, that was showing that like 70% of patients with endometriosis had interstitial cystitis. I think that we're probably overdiagnosing. I think that a lot of what we are classifying as interstitial cystitis probably has more to do with adenomyosis. If you
Okay.
think about the bladder sits right on top of the uterus, and if that uterus is inflamed, it's going to transmit pain signals and irritative symptoms to the bladder. And so patients, especially like if there's a cyclical nature to those bladder symptoms, like, oh, I don't have bladder symptoms during the month, but when I'm on my period, I'm up 4 to 5 times a night to pee. I feel like I can't empty all the way. I'll pee, and 10 minutes later, it feels like my bladder's full again. That's probably the uterus. And those symptoms will go away once the uterus is gone.
Hmm.
But there are patients who do have true interstitial cystitis, and that's they just feel like they, all the time feel like they have a bladder infection. They feel all the time like they have to pee. These are patients that are peeing 20, 30 times a day. I mean, it's miserable. IC is a really miserable disease.
My
Uh,
grandma actually had it and ended up having a urostomy for that.
mm,
So I was kind of
yeah,
asking, because I know it
yeah,
too, like endo runs in families. It's kind of more of a genetic thing. And so
mm,
it's kind of interesting piecing together like my family
yeah,
history, be like, oh, you
yeah.
know.
My mom has interstitial cystitis
Okay.
as well, and that's kind of how, my introduction to the pelvic pain world. But so it does, we do see it, and that's a pretty extreme. where they, will actually remove the bladder and do it or bypass the divert away from the bladder. That's called the Miami pouch, and they take a piece of small intestine and essentially sort of create a neo bladder within the body that the kidneys drain into, and then it comes out into a bag outside your body. So it's just a way to bypass the bladder completely
Mm.
in patients. And I've had patients who've had that done. There's a surgeon down in Salt Lake City, a urologist that does them, who I have sent patients to. And I've had a number that have just gotten so miserable with their bladders that they're just like, I'm just not even going to have a bladder.
Mhm.
That's a better alternative. So I have had those patients who've gone down to Salt Lake and had that surgery done. Yeah.
Mhm. So, and it is kind of a genetic, like, and going back to endometriosis, it is
Yeah.
genetic, right? That's kind of where you think everything is coming from, or.
Yeah, I mean, I think everything is genetic on some level. Blood pressure, heart disease, cancer. I mean, I think everything is genetic, but there's pretty clear data. I don't know the data on genetic inheritance rates of IC, but we know that maternal inheritance rates for endometriosis are about 70%. So if a first degree female relative has endometriosis, there's about a 70% chance that you'll get it. There's also paternal inheritance rates too, and those are lower. They're about 20%. But if like your dad's mom has endometriosis, there's about a 20% chance that you'll inherit it. So it's a little, it's lower than the 70%, but it is still there. Um, so, I mean, we've identified over 300 genes, though, that contribute to the expression of endometriosis,
Oh,
and
wow.
most of those are tumor suppressor genes or cancer genes. So we've kind of always lumped endometriosis. We've known for a long time that breast cancer, for instance, behaves very differently than prostate cancer or pancreatic cancer or um, you know pancreatic, whatever bile duct cancer, whatever it might be. So like we've known for a long time that not all cancer is cancer, or is the same. Cancer is very different, but we've always sort of lumped endometriosis as just sort of one disease. It's just endometriosis is endometriosis, but there are subtypes within endometriosis. We haven't classified them yet, but that act very differently from one another. Some endometriosis will respond beautifully to hormones. Some won't. Some will respond to surgery, and some won't. Like there are patients I've operated on, and 6 months later, their symptoms are back, and you scope them, and all their endometriosis is back. Um, I have a patient who had surgery with a very well-known excision specialist. I won't say where, but and then came back and had excision surgery with another well-known excision surgeon. And like these are people that I know, and I know they didn't miss disease. I know they
Yeah.
didn't miss. These are surgeons that I trust. I've known for a long time. They have great reputations, so they didn't miss disease. And this patient is wanting me to do a laparoscopy for a third time in 2 years on her, and she's already had two excision surgeries with very well-known specialists. And I'm like, I'm not gonna fix you. That's a hard conversation to have. Like I'm not gonna a third surgery in 2 years is not gonna fix you. And when she had her second excision surgery with a very well-known doctor, they found disease in all the places that the first surgeon had excised. And so
Wow.
I'm talking to this patient and saying, you've had this will be your third surgery in 2 years. Like this is clearly very refractory endometriosis that is just going to come back no matter what. And you can't do surgery every year for the rest of your life. I mean, this person is 30 some years old. Like you can't do surgery every year for the rest of your life. So those are patients, they're very, very rare, but those are patients that you have to just start talking about. We have to just try to like suppress symptoms at this point because surgery is not the answer for you. And eventually, I think on the forefront, and it probably won't be in my lifetime because endometriosis, any women's health is criminally underfunded, but especially endometriosis. Um, if this was a disease that affect dudes, you can bet there would be billions allocated towards it. But right now it's like, well, okay, you're in pain, boo
Mhm.
hoo. Um, and so eventually, I think the point we'd all like to get to is we still have a role for excision surgeons. So an excision surgeon like me goes in, removes the endometriosis. We send it to a cytogenetics lab where they can genotype it and tell
Mhm.
us like exactly what genes are at play here. And then we might have a better understanding of, okay, is this patient gonna respond to surgery? Are they not going to respond to surgery? Are they going to respond to hormones? Do we put them on, hormonal suppression after surgery? That's another very, very controversial topic, and we might not have time for that one. We might have to do a part two. I think we're gonna have to do
Okay.
a lot more to talk about. But eventually that's the goal, is that we can remove a piece of endometriosis, we can send it to a lab, and then we know exactly what we're dealing with. And then eventually maybe even have like targeted gene therapy
Yeah.
where the way that they do with cancer. And they have so many different cancer medications now that work on a genetic level where they can target specific genes that are being expressed by that cancer. We don't have that for endometriosis.
Gotcha.
And once we do, ideally, that'll be the end of endometriosis,
Hmm.
you know.
Hmm. How far
Um,
out do you think that would be? Like you said, not your lifetime necessarily, or
Not my lifetime. Yeah, I'm guessing a ways down the road,
yeah,
but I don't know. I don't know. Maybe someone's almost at that breakthrough.
yeah.
Um, but it'd be nice. I think the other sort of holy grail of endometriosis would come from a diagnostic level where we could have a scanner that we would put a patient in that would be 100% definitive for endometriosis lesions. There was some research kind of going into that, similar to like a PET scan for cancer.
Okay.
You put a patient in a PET scan, and you have these radioactive isotopes that
Mhm.
specifically target enzymes that metabolize sugar. And because cancer metabolizes sugar at a higher rate than normal cells, these radioactive isotopes like attach to those, and they light up on a scan. And that's the basis for a PET scan. I'm not a radiologist, so I may have screwed up that, but sounds good. But eventually we'd have a machine that would definitively like light up endometriosis. And that would be helpful for so many reasons. But first and foremost, there would be no denying patients the idea, there would be no telling patients the idea that they have endometriosis is ridiculous or it's in their head. Patient could come in to their OBGYN and say, hey, I'm having pain, and instead of the doctor just being like, oh, it's in your head, just ignore it. You're probably just stressed. Have you tried drinking a glass of wine? Have you tried, all the stuff that people get told? Um, they just go in this magic scanner, and then there's no doubt, there's no denying it. And then it would also help us on a level like for a preoperative mapping, like
Yeah.
we get these scans and we know, hey, there's endometriosis all the way into this bowel. I for sure am going to need my surgeons.
Mhm.
Or there's endometriosis that's blocking this ureter, I'm going to need my urologist, so that would be really, really helpful. I think something like that is probably closer than the cytogenetic, the genetics
Yeah.
aspect of it, but I'm hoping that that'll be within my lifetime.
Yeah.
So
And right now, like endometriosis doesn't even show up really on scans, right? Unless you had like a cyst or an endometrioma or something like that, right?
yeah, that's correct. So there are doctors out there who are pretty good with ultrasounds and pretty good with imaging, who are, say they can see all disease on with an ultrasound. I don't buy into that necessarily. So MRI is probably our best modality for imaging. And if there is, so there are instances where you can see endometriosis, like you mentioned, the endometriomas on the ovaries. Those are always gonna show. You're always gonna see those on an ultrasound. But if you've got like deeply infiltrative endometriosis of the bowel, so if you have bowel invasion, you're probably gonna see that on an MRI.
Okay.
And our imaging is getting better. Or if you've got endometriosis in a really confined space, like on the sciatic nerve or something, where it's like actually like causing it's actually filling up space within a
Mhm.
cavity. Because like in the abdomen, right, it's a big cavity. And so if you've got endometriosis lesions, they're not gonna be big enough that they're gonna like push other things out of the way. They're just gonna be sitting there. And
Gotcha.
you're not, but if you've got a nodule of endometriosis in a very confined, like in a kidney or on the sciatic nerve or something, you are generally going to see that on imaging because it's going to create a mass effect there. Uh,
Okay.
so our imaging is getting better, but it's not perfect. And so I think, from my perspective, the best way to diagnose endometriosis is just to listen to the patient, and they'll tell you they have it.
Gotcha.
So
Gotcha. Is there any other treatments that you kind of recommend go alongside, excision surgery? I mean, I know pelvic floor, obviously, I'm a big fan
yeah,
of
I,
that, but
I,
anything else that
I,
you recommend?
I'm always plugging for pelvic floor physical therapists. I think that their job is far more important than my job. I'm a cutter and I remove the endometriosis, but typically after years of untreated endometriosis, there's going to be a lot of residual damage to pelvic floor. And so the pelvic floor physical therapist, I think outside of excision surgery, pelvic floor physical therapy is the best treatment for pelvic pain. And I think a combination of the two is kind of should be the gold standard. And then, but on a like people always ask me about like anti-inflammatory diets and gluten-free and dairy-free, and there's not ever been any evidence on a larger scale that any of those dietary changes work. I think on a patient to patient level, on an anecdotal level, yeah, there's probably something to leading a low inflammatory diet, sugar, dairy, gluten,
Mhm.
all of those things. And, just because the evidence doesn't show it doesn't mean that it can't help. I don't recommend those things exclusively. I don't say,
Yeah,
oh, just cut out dairy, gluten, and sugar, and all of your endo will go away. But
yeah,
I do think on a patient by patient level that some of those changes can be beneficial. And I mean, so we've seen the incidence of endometriosis diagnosis
Mhm.
just skyrocket since the 50s. Is that because we're getting better at diagnosing it, or is it because we are exposed to things that are causing, estrogen to be metabolized differently in our bodies? I,
yeah,
I don't know. I think there is something to that like we're the amount of, you think about like sunscreens can cause,
yeah.
the hormones in meat, even though they're supposedly not have hormones or antibiotics in them, they do. The just all the things in our environment that are potentially altering at a cellular level the way that we metabolize estrogen, progesterone, testosterone, all of these sort of sex hormones that are so critical in the expression of diseases like endometriosis. I do think there are a lot of environmental factors that we just don't know about. And so I do think that when we see those numbers, going up, but we're also seeing numbers skyrocketing of other autoimmune diseases too.
Yeah.
Um, and things like, um, neurodivergent, autism, Asperger,
Mhm.
all of these things, like we're seeing these huge increases in all of these diseases, autoimmune things, Hashimoto's. Is it because we're getting better at diagnosing them, or is it because there truly are environmental factors? I think it's probably a combination of both. And
Right.
so I think it never hurts to try to live clean,
Right. Yeah.
so it never hurts to cut out processed foods and
Lots of
uh,
sugar and
I mean, I love sugar, but
me too.
but, but it's like, everything in I think, the Greeks had it right, everything in moderation, right? Alcohol, sugar, dairy, I mean, all of those things are probably contributing on some level to some of these autoimmune conditions that we're seeing. And we don't truly know, is endometriosis like an autoimmune condition? Is it a central nervous system disorder? Is it why do some patients have minimal disease but horrific pain? Why do some patients have horrific disease but minimal pain? Like we don't know any of these things. And so I do think there's, on a case by case level, I do think there's a role for living cleaner, eating better, eating healthier, exercising, all that stuff.
I mean, I
So,
think just health promotion in general is going to help so many
right,
things. It's not going to hurt anything to do any of that. It might not be the end all be all,
right,
quick fix, but it's not going to harm
right.
anybody.
Certainly not a quick fix,
Yeah,
but again, neither is surgery.
yeah,
So
yeah,
it's quick sometimes. I mean, it's a quick relative, but you still have pelvic floor dysfunction. You might still
right.
have bladder pain, uterus pain. There's all these other pain generators. So, surgery is great, but it's certainly not perfect either.
Yeah,
So
yeah,
we always have those conversations with patients, like sort of managing expectations of like you're not going to wake up from surgery and everything's fixed. Like it's not how it works. There's
yeah.
going to be a long road ahead with pelvic floor physical therapy, with healing, with addressing other factors. Mental health, I think, becomes a big aspect of it, like addressing mental health issues and addressing trauma. And like there's all these other things that play into it that other than like just endometriosis.
Mhm.
So Yep.
Awesome. Sweet. I think that is all of my questions. Real quick, where are you located? Where can people get a hold of you if
Yeah.
they
So
have any info or
I'm at Northwest Specialty Hospital in Post Falls, Idaho. My partner, Dr. Young, and I are both fellowship trained endometriosis surgeons. And you do not need a referral to see us. So you just call us 262-2482, and we're happy to see you. We have a physician assistant and nurse practitioner also to kind of help get patients in. And yeah, we're happy to see anybody. But yeah, you don't need a referral. That's, I think, the important thing to remember is you don't need a referral to see us. I think a lot of people also think they have to have a diagnosis of endometriosis before they can see us. That's also not true. If you suspect you have endometriosis and you've been talking about it with other, clinicians for years and really haven't gotten anywhere, it's definitely good to be evaluated by a specialist. So,
awesome. Awesome. Sweet. Well, thank you so much for
all
taking
right.
the time to
Yeah.
chat and
Hey, you're
everything.
welcome. Okay. Have a good one.
Awesome.